Hello, good morning. This is Anna speaking from Hamburg. I thank Oksana Grosu and this scientific board of this virtual congress to put cluster headache and related syndromes in particular in such a prominent position. In the next 30 minutes, 30 plus minutes, I hope to achieve three things. To convince you that cluster headache and indeed all TACs are easy to diagnose. Secondly, the fact that whatever pain specialization you are working in, it is really highly probable that you will see such patients. And thirdly, to highlight shortly some pathophysiological aspects of a fascinating disease, and also to focus on how TACs are treated, including new and sometimes very new data. I try now to show you my slides. And I do hope that you can see them and also see here this little duck. No, it's not a duck, it's a canoe. That's Hamburg, actually. Because if you see the canoe, then my pointer is working. I will find out in half an hour. Here you can see where I'm based. That is Hamburg in Germany. Hamburg is perhaps the most, I think, beautiful city in Germany. Based in the very north and next to the sea. It has a huge harbor and beautiful buildings. On the right upper corner, you see the here from the city landmark, the so-called the symphony, the Elb Symphony, and here you see the university where I'm based and working. Let me start with introducing my group. I'm very proud of these young people. I even have some dentists working with me since I'm lately becoming very interested in facial pain. I have some corporations. Since I'm a scientist, I'm funded by national and international groups. And since I will talk about medications, it's very important to point out that I have no conflicts of interest. Since I'm the editor of cephalalgia and cephalalgia reports, I'm requested for transparency reasons not to give lectures or consulting to any pharmaceutical company. This is the UKE, University Clinic Hamburg-Eppendorf. If you walk in here and then down here and then up the corner, they will find the headache special outpatient clinics. We see 1,000 to 2,000 to 1,200 patients per year. We are the largest German headache clinic at the moment. We have a specific even outpatient clinic for trigeminal autonomic clinics patients and also for facial patients. I find, and this is why I nicked this picture from the internet, that cluster headache is an absolutely remarkable disease. It's a headache that strongly differentiates between days and nights and will come up at night. Headache where 23% of patients get one or more teeth extracted before the correct diagnosis. So a lot of them go to the dentist before they see you or me, and none of these teeth extractions, of course, have an effect. A headache that knows exactly when summer is, and then it stops because it's mostly there in autumn and in spring. If you cure this headache locally, then it may change sides. But a headache, when it's there, when it's decided, never changes sides. So you have a headache which is so-called side locked, only on one side, and you should never in medicine say never. But it's so rare that it does change sides that it's nearly okay to say it does not switch sides. If you, however, cure it locally using stimulation or something like that, then it may switch sides, and that's not uncommon to hear. Here I bring you a clinical case, really absolutely typical. It's a male patient, typical as well, 43 years old, with a facial pain and headache since 6 years. It's episodic. The episodes last for 3 to 4 months. The headache-like pain starts in the upper jaw and then spreads to the eye and sometimes to the temporal region up here. Always one-sided. It never changed sides, so side-locked. The pain quality is absolutely extreme, 10 out of 10. Rather exploding, lasts up to 2 to 3 hours, and the patient notes some tearing of the eye, but also a blocked nose, but only on the side He's not crying. It's really on the side where the pain is. He presented himself at three different dentists, one ophthalmologist, two neurologists, and had then got teeth extractions twice and new glasses. When he saw us, the clinical examination is absolutely normal neuroimaging, and the medical history is unremarkable, but for a known depression. This kind of disease, really absolutely classic, has been not always been termed cluster headache, but erythroprosopalgia comes from the Greece, red face and pain. So the combination of those was thought to be this kind of headache. People who, medical doctors who really clearly described the disease for the first time in completeness were Robert Bing from Switzerland and Bayati Horton from America. And here you see the original publication in German where they, from Bing, where he described these erythroprosopalgie. And really, he put down what we say nowadays is a cluster headache. That's the International Classification of Headache Disorders, of course, and it's an absolutely severe headache. It's around the eye. It goes up to the temple. It lasts 15 minutes, 280 minutes, and it can be one attack every other day or up to 8 attacks a day. When these people have this kind of pain, then they have either an autonomic symptom on the side of the pain or a sense of restlessness, or most of them have it both at the same time. Here you see quite nicely how the autonomic symptoms look like. That would be outside of the attack. Inside of the attack, you see there is a redness here. Looks like an inflammation. It's a tearing on that side. This guy has an miosis and ptosis, so an Horner syndrome, and the nose was running as well. This is a very recent study published 1 or 2 months ago in Headache, 1 or 2 months ago and a year ago in Headache, which describes in more than 100 patients just how severe this type of headache is. And you see here that in 1,000 patients asked between 0 and 10, how worse is this kind of pain, that it was nearly always a 9 or a 10. They didn't even start below 7. Now, they then compared this type of pain to other pains. And so a large organ biopsy, no one of us wants to have that, would be around 4. A myocardial infarction is around 5. If you break your bone, it's about a 5 again. Migraine attack would be around a 5. Gunshot wound, 6. Nephrolithiasis, really extreme pain, 7. Cluster headache, nearly 10. So it's an absolutely enormous, it's a devastating pain attack. And this is another rather recent study published 2 years ago, 1.5 years ago, which investigated now the diagnostic delay in cluster headache. That means how long does it take between the first symptoms and the correct diagnosis? And although this type of pain is unbearably dreadful, there is still a diagnostic delay of cluster headache. In the 50s, here, it took up to 40 years. And even in the last decade, it was around 4 years. Diagnostic delay was reduced for every decade investigated. And it needs to be pointed out, however, of course, that if there are some atypical cluster headache features, such like length of attacks, side change, aura, and so on, that would obviously play into a prolonged diagnostic delay. Still, one has to say it's very easy to diagnose. Attacks on the same side, really severe, not lasting longer than 2 or 3 hours, and ipsilateral autonomic symptoms. It's as easy as that. Still, the diagnostic delay is years, and that is shameful for doctors, I think. Here you see that cluster headache comes up usually in episodes, and that's why it's called cluster. So if you have 1 year, then most of the year it's free of attacks, and then these clusters, the attacks cluster around one point, and then they stop, and then they cluster around another point, and that's why it's called cluster headache. Most of the patients are episodic. Episodic defined as there is at least in 1 year a attack-free time of 3 months. If it's less than 3 months, it's chronic. And here you can see that some patients never had a episodic-like type, but start with a chronic type, so they never have really medication-free times where they don't have attacks. And it can start episodic and then later secondary become chronic. This is rather older study published 2010. That was just a case report of one man who had a chronic cluster headache and really meticulously put down each single attack, how long it lasted, what kind of medication did he take, what was the moon cycle, what did he eat beforehand, and so on and so on. And he managed in 10 years to nearly document 5,500 attacks. And you can see that in these 5,500 attacks, there was still a clear-cut circadian rhythm. So this is 0, this is 24 hours. You can see that at night, these attacks, they could happen all over the day, but at night, they were significantly more so. And if we put that into a equation for the whole year, you see 0 to 12 months, you see quite nicely that there is a biphasic increase, which was significant again, meaning that the episodic cluster headaches, which are usually the episodes are at specific years of the time, so autumn and spring, that even in cluster headache, chronic cluster headache patients, this kind of circannual rhythm, this oscillating over the year, still happens, meaning that in such a patient, he might tell you here that his medication is not working. That is not completely true. It doesn't mean that you have to now switch all kinds of medications. It means he needs, perhaps because the headache cycles and is more severe here in spring, that he may need more medication here, and the usual medication down here. This, I think, is an absolutely remarkable study, and the results still puzzle me. It has been done here by Kuan-Po Peng, who is from Taiwan and works in my group since several years now, fortunately for me. Tsubasa Takisawa, who is from Japan, and Miji Lee, who is from Korea. And they compared the clinical phenotype of cluster headache patients between Caucasian and Asian populations. And there were several smaller differences, but the most striking for me is the fact that chronic cluster headache is rather rare in Asian countries. There is also a stronger male predominance, and the clinical presentation of restlessness was not as common in Asian as it was in European and North American countries. This study means that regional differences in the presentation of cluster headache exist. The authors concluded that greater awareness for cluster headache should be raised in Asian regions, and there is no question that further studies are warranted, I think, to elucidate the mechanisms behind these observed differences. Fascinating, really. There are secondary causes for cluster headache known. Here you see just two examples of a macroprolactinoma and another case of pituitary adenoma. Other causes have been described, and it needs to be pointed out that the dissection of the carotid artery can mimic cluster headache and should always be excluded. What is interesting, I think, is the fact that if intracranial pathologies exist, a tumor, a prolactinoma, anything like that, and that causes the cluster headache, that these pathologies can in principle be everywhere in the brain, so really from the top to the bottom, back to front. However, they're more likely to be somewhere in the midline, and no one knows why that is the case. Here's Peter Goldsby, a younger Peter Goldsby, who 1997, together with Richard Lipton, published in Brain a whole group of patients what they then coined trigeminal autonomic cephalalgias, and that's where the word TAC comes from. And he just put together that not just cluster headache is such a TAC, but others are as well. And they have all in common that they are strictly half-sided, that they come in attacks, that these attacks are short, and that there are autonomic symptoms at the same side. And so just to follow up on this, TACs, here you see the different ones, and so you see they are different in different things, but however, the most important one is really the duration of the attacks. So cluster headache, up to 180 minutes, paroxysmal hemicrania, up to 45 minutes, Sung syndrome in seconds, and hemicrania continua, like ongoing. Hypnic headache is only at night, up to 120 minutes. You can see that here is an overlap. So if you have someone within like 15 minutes, 20 minutes, 30 minutes attacks, it could be a cluster headache or it could be a paroxysmal hemicrania. In such cases, it's important to know that indomethacin works in paroxysmal hemicrania and it works in hemicrania continua. And that's the definition at the moment. They always work in 100%. I personally think that's not true. There are patients with paroxysmal hemicrania where they are indomethacin insensitive, but in most patients, that is probably true. Indomethacin does not work in cluster headache, per what people say. I do know that in some cluster patients they do work. So it's not. Of course, medicine is not absolute, and of course, this is not like robotics. But in general, that's true. Intercluster headache would not react to indomethacin, whereas paroxysmal hemicrania and hemicrania continua work rather nicely to very small doses of indomethacin. So if you have a patient who is in between these two borders, why not try indomethacin and see whether it works? Starting with three times 25 milligram and then increasing 25 milligrams per day up to 3 times 75 milligrams. You would work then for cluster headache with verapamil. The same holds true for hypnic headache. And for the Sankt syndrome, looks like an trigeminal neuralgia, but here really only on one side, always above the eye, and with the tearing and a blocked nose, then you should try then perhaps lamotrigine. So obviously, they are all one bunch of syndromes, which have the same syndromal pathophysiological background, but because they are distinct in terms of clinics, as you can see here, they are distinct in terms of how you treat them as well. So in summary, clinical part, there are some key symptoms in cluster headache. It's the attack length, it's the pain localization, side locked, it's the autonomic symptoms on the side of the pain. There is a circadian rhythmicity, and these people are restless. They rock or they run around. This really is a how to say that, a spot diagnosis. That's a 32-year-old man with extreme, strictly left-sided headaches with stinging character, fluctuating intensity since 20 hours, and ipsilateral autonomic symptoms. Rather nicely, a Horner syndrome on that side, redness of the eye, tearing of the eye, and this redness here as well. But that it was not a cluster headache. There is a red flag up here, and the red flag would be since 20 hours. We have talked about cluster headache. Cluster headache is the longest 3 hours, usually 1 hour or 2 hours, maybe up to 3 hours, but not 20 hours. So something is wrong. Of course, you need to do an image there, and then write quite nicely a dissection of the carotid, of the internal carotid, could be shown. That would be the spot diagnosis. It looks like a cluster headache. It's a differential diagnosis. However, it's another kind of disease. That would be the most important differential diagnosis in acute attacks that never happened before. This is a study which was, I think, important to know. Here, Charlie Gaul and Stefan Evers asked cluster headache patients to draw on a map where it hurts most. And you can see the more reddish it is, the more it hurt on that side. So really around, on the temple, around the eye. But there are people who say it goes down here into the face, remember the dentist, and it goes down here into the neck, meaning this is what you expect, but it could happen somewhere else. And rather rarely, I oversee now 3 to 4 patients who have a cluster headache only in the back and not in the front. It seems that these patients have no or little autonomic symptoms when it's only in the back. This study I found rather interesting as well. It's a bit older, 2007, and here 9 patients with cluster headache were looked after, and you see that in these patients, the autonomic symptoms were on the side of the headache, ipsilateral. However, it was a little bit on the other side as well. So it looks as if the autonomic symptoms, if you look closely enough in these autonomic tucks, are on both sides, but they're more prominent on the side of the headache attack. So maybe it's a bilateral disease, which is just prompted to be on one side. So the other side is somehow compressed and does not come out. Now, if you treat it locally, it could well be that comes out on the other side as well. That would explain why it then shifts sides. This study is just to point out that these autonomic symptoms can also occur in migraine patients and may be presented in up to 40% of patients with migraine. This is not to make you confused. It just shows that the presence of autonomic symptoms alone does not allow for the diagnosis of a trigeminal autonomic headache. The length of the attack is very, very important. If you have autonomic symptoms in a patient who has an attack that takes 24 hours, then it's a migraine with autonomic symptoms. If you have these autonomic symptoms in a patient where the attacks are just 1 hour, then it's more likely to be a cluster headache. So only really the combination of attack length and autonomic symptoms on the same side allows the diagnosis after secondary causes, of course, have been excluded. Now pathophysiology, cluster headache, the why and the where. We have to explain, if we want to explain cluster headache, we have to explain why it's a trigeminal pain only, not somewhere else in the body, why it's more in the first division. It may spread to the face, remember the dentist, but it's more really likely behind the eye and up to the temple. And then we have to explain the autonomic activation on the same side, which is not there in only 3% of patients. We have to explain then the circadian rhythmicity, and we have to explain the good response to high flow oxygen. And please allow me here to cite Peter Goldsby, who said, it is, so some of you could think, why do I want to know where it really comes from? It's enough if I can diagnose it and then treat. And Peter Goldsby said, it is in principle, really always in principle, useful to understand as much as one can about the basis of a disorder, because cluster headache patients are remarkably well informed. They can also be remarkably assertive about the way they're well informed. It's not a bad idea to know something about what you're talking about. It's a very good idea that if you don't know what you're talking about, maybe it's best to say, not very much really, because the patient may know and read a lot. Is there any kind of trigger? Yeah, there is. Triggers are alcohol and triggers are histamine, and they would make in controls a slight immediate headache, histamine, nitroglycerin, for example. In migraine, they would give you a migraine-like headache, but after some time, sometimes up to several hours until the cluster headache comes up. In cluster headache, it's completely different. A cluster headache, if you drink alcohol, in the next 20 minutes, they will have the full-blown attack. However, only in the bout. Outside of the bout, they can drink as much alcohol as they want. Bout would be the active period when they can have these attacks. So outside of the bout, when they are episodic, then they can drink alcohol, but inside the bout, it's a catastrophe if they do. This means that there is not a human model that can mimic cluster headache. So it's not that we can somehow in humans or animals mimic these kind of diseases, but you can mimic it at the very moment the pathophysiology is involved. So if someone has a cluster headache attack and you give them histamine or alcohol, these attacks come up. And you cannot evoke attacks when between bouts. Why do I talk about this? This is important to know because you can prevent attacks, as you might know, and as I tell you in a minute, if you use a prophylactic like verapamil. But verapamil, however, can prevent attacks, but it cannot prevent active episodes, meaning, as I tell my patients, you have somewhere in the brain like a switch. And if the switch goes on, then you are able to get attacks. If you then drink alcohol, you will get an attack, and the attacks come in spontaneous as well. Now, if we give you verapamil, then that means that we do not interfere with the switch. We cannot do that. What we can do is we can, in the periphery, help you that these attacks don't break through. Meaning, the very moment we take away verapamil, and if the switch is still on, then the attacks come up again. Now, if the switch itself goes off by itself, and we can't change that, and we cannot make it happen. But if it's off, then obviously, and now comes the consequence of all of that, that means that patients need verapamil not when they're off, when the switch is off. And that means, and I see a lot of patients still who take verapamil for the whole year, although they have only 2 months of attacks. It means here to explain to the patient what happens in terms of central switches, and that we can only work in the periphery, and then that they themselves have to find out when these headache attacks go down again and when the episode stops. And then they can stop verapamil and they don't have to take it for the rest of their life. This was one of the early ideas why this kind of headache comes up. This is a carotid artery, and with the carotid artery come up some trigeminal trigeminal phases, trigeminal fibers. And these fibers go then here with the carotid artery through the cavernous sinus. And that is very narrow, and there's a bony canal. And if there's an inflammation here, then they would have that the trigeminal nerves are pressed to the bony canal. And that would give a pain on the same side. And at the same time, here, some through the cavernous sinus, some autonomic fibers go through. And because if you have the pain on the same side, at the same time, you get then the autonomic symptoms of tearing of the eye and a blocked nose or running nose. However, we cannot, with this idea, explain why it's strictly half-sided. We cannot explain why it comes in attacks and oscillating attacks, if you want so. We cannot explain the circadian rhythmicity or the annual rhythmicity. And this was a rather old study now where cluster-headache patients went into the scanner and were asked to lay completely still and have an attack after nitroglycerin. And you can see that when they do this there are some activations in the brain here in yellow. And this is just the so-called pain matrix, meaning they have pain while lying in the scanner. This here was new. This was not seen in other pain studies, like here in healthy controls. This is the next to the hypothalamus and explains why these patients have these kind of attacks. And here quite nicely see that this one study was then replicated by several times, really, and always in these kind of headache syndromes, this activation here in the hypothalamus comes up, meaning that hemicrania continua, paroxysmal hemicrania, Sunk syndrome, they all are really one class of headaches, but remember, they are one class. They have one reason, so one cause, how to come up, a generator in the brain next to the hypothalamus, which turns on the attacks and turns off the attacks, but they are slightly different. We don't know really why they are different, and they're differently treated. Still, it's really reassuring that this one study here was replicated so many times. And this is, all of this was really, most of this was PET studies. This is now an fMRI study. And we could show that this activation here in the hypothalamus is in the inactive cluster most activated, in the active cluster less, and in the healthy controls it wasn't. Meaning there seems to be an oscillating activation in this region, and this oscillating activation explains why some patients go in and outside of the bout. Now there is so much evidence now that the hypothalamus, this is the third ventricle, that the hypothalamus here is activated in these attacks, that an Italian group, Francini et al., did a deep brain stimulation like in Parkinson's disease in exactly this region here. And they could show here, this is an older study and there are some, but with the same result, that really around 50% of patients have a good response with less attacks and that or even no attacks anymore. Meaning you can switch on and switch off if you hit the right spot in the hypothalamus. This is a rather newer study here in meta-analysis of other studies and among 40 patients from 4 different cohorts that represents about 50% of all previously published cases. The authors here found and described a significant reduction in headache attack frequency over a mean follow-up of 44 months with an overall response rate of 75%. This is really solid. Positive outcome, however, was not associated with clinical baseline covariates, so you couldn't beforehand say who will have an effect. and they identified two hotspots of stimulation covering the midbrain ventral and retrorubral tegmentum. Here, if you hit really in these spots, then it's most likely that you can stop these attacks in these patients. So summary, pathophysiology, the major players of the pathophysiology background you can see here. It's the trigeminal ganglion, it's the trigeminal nuclei, it's the and the information would come in here, then go up to the hypothalamus and thalamus. You see the cavernous sinus that we talked about. You see the sympathetic fibers going through the cavernous sinus. You see the parasympathetic fibers here connected to the SSN. So and a functional connectivity between the trigeminal nuclei and the SSN. So information coming in here would then be relayed through TNC and C1 and C2, then goes up to the thalamus, but also goes up to the SSN and has a parasympathetic output through the ganglion pterygopalatine. The underlying pathomechanism is characterized by a synchronized abnormal activity, what we believe now here in the hypothalamus, and the trigeminal vascular and the autonomic nervous system. And based on all what I told you and the clinical neuroimaging data and also the findings of neuromodulation techniques, a fundamental role of the hypothalamus in the initiation of an episode and the generation of an attack seems likely, whereas an activation of the peripheral nerve system may be required for the occurrence of this kind of pain. So this is probably the generator. It doesn't mean that the nociceptor is here. The pain is not generated here. Something is generated that disturbs the whole system, and that gives then these kind of attacks. Now we come up to the last part, and that is treatment. And when we first talk about acute or abortive treatment, that it needs to be mentioned that by and large, cluster headache is the only headache that responds to inhalation of oxygen, of pure 100% oxygen. There are several well-done placebo-controlled RCTs now published, and if you prescribe oxygen, you should always insist on 7 to 12 liters and 100% high-flow oxygen delivered via a rebreathing or a demand valve, rebreathing mask or demand valve. So if a patient tells you oxygen does not work, then ask him how did she take the oxygen. And if it's less than 7 liters, then you don't know whether oxygen works or not. If it's 12 liters and it didn't work using a rebreathing mask, then they are one of the 30 to 40% of patients where oxygen does not work. But you should insist on to try out 100% oxygen, 7 to 12 liters. Triptans, all the triptans do work, and actually we know that in all these medications, the triptans in terms of tablets also do work. However, they take too long. So the attacks are very short. So you don't want to just take a tablet and wait for 40 minutes until these kind of attacks go away. This means that sumatriptan subcut or a nasal spray is the medication of choice. And we know that a lot of patients with the sumatriptan nasal spray have a very good response in the next 5 to 8 minutes. One could try lidocaine. If you try lidocaine, you should give it ipsilateral to the pain. Not ipsilateral to, lidocaine, that's the point. You need to put ipsilateral to the pain. So the patient needs to lie down, and then when the attack is on the right-hand side, put the lidocaine into the right-hand side and spray it really deep into the nose. What you want to then have is that there's a numbness here between the eyes. Then it's more likely that it works. If you use, however, a triptan spray, then you wanted to use it on the other side where the pain is not. Remember, you have autonomic symptoms, the nose is blocked or running, and if you then put the nasal spray on the same side, it can't work. So you need to do the sumatriptan, the triptan spray on the contralateral side. If you use lidocaine, you have to put it on the ipsilateral side. Here you see the preventative medications, and verapamil really is our working horse, and we start with 3 times 80 milligrams. It's very important to use ECGs as well. And this is a study published 2021, a multi-center study that showed that oral prednisolone, if you give it in a short-term preventative therapy in this population of patients, then you have a positive effect, meaning cortisone does work rather nicely. Cortisone has a problem of huge side effects. So you give it in the beginning, 100 milligram for a week, and then you go 20 milligrams down and taper it out because you want to use verapamil. Verapamil you can't put in so fast. And to bridge the thing until the time until verapamil does work, there is now a good study telling you that it would be a good idea to use prednisolone for 5 days. So that would be the working horse. Never forget the ECG. Then we know that lithium works rather nicely, either in combination or alone, and with topiramate, it's the same. These two have more side effects. This is why we usually start with verapamil, going up to 500-600 milligrams, then going down to 400 if it doesn't work in the monotherapy, and then add on lithium or add on topiramate. Then the big question now, of course, is whether the medications that work in migraine and are thought to be medications that have a specific effect on the trigeminal nerve, the medications that involve CGRP, and here the CGRP antibodies, whether they do work. And here you see studies published that galcanezumab has shown to be efficacious. It reduced the frequency of attacks in episodic cluster headache, but not in chronic cluster headache. While fremanezumab failed its primary endpoint in episodic cluster headache, and both fremanezumab and galcanezumab trials in chronic were terminated because it didn't work. This means that CGRP antibodies are recommended only for episodic cluster headache patients. And if so, then galcanezumab is more likely to be given. It's approved in America by the FDA, but it's not approved by the EMA, so the European authorities, meaning that it can be prescribed in the US, but it cannot be prescribed in Europe. That having said, here you see OPENS trials. Now we know that the double-blind studies failed. In open studies here, more and more case series are published that CGRP antibodies are effective in some cluster headache patients. And here's this recent publication about it. I find it important to say that we need more data and studies and should still now consider to treat patients if all other medications fail. Then you should go to the insurance company and say, look, everything fails. We should try in these patients before we start to operate. What else can you do? Here you see that there are some possibilities, most of them not well studied, certainly not double-blind studies. This I find very important, a diagnostic and therapeutic blockade. It's very easy. You cannot do much wrong. And it's effective in a lot of headache patients, actually, and also in cluster headache patients. So what you do is you go to the back of the head, interestingly. So they have the headache here. Still, if you block the occipital nerve here, which is a purely sensory nerve, you can have an effect on the trigeminal nerve. So what you do is you put your thumb here on the back of your head, and that's the occiput. And then you put your index finger here on the mastoid. So you go otherwise this way, and then with your thumb you go from the mastoid down, from the occiput down to the mastoid. So in this trajectory, I show it here. In this trajectory, go down and you just press. When you do that, then the patient will say at some point, that's different. Here is something different. Maybe it's more problematic on the side where they have the cluster headache and on the other side. Then you know where the GON, the greater occipital nerve, goes around the bone here and then goes up as a sensory nerve to the back of the head. You could then take 4 milliliter of lidocaine and 4 milligram dexamethasone and then inject it in here. Not much you can do wrong. And we do have patients who are then for a week or even 2 weeks, some for a month, completely medication free. So this is really easy to do, less side effects, and it's really a practical tip to try out. We even do it in trigeminal neuralgia, and it does work in patients who have, for example, MS. And you know, if the combination of multiple sclerosis and trigeminal neuralgia is very hard to treat. And then it's a trick to do this kind of thing and help a lot of these patients. And I do have patients who come only every 3 months, get an injection, and are nearly pain-free and medication-free for the next 3 months. There's just one other possibility. There is the transcutaneous stimulation of the vagus nerve using the gamma core device, which looks like this. And that has been shown to be effective in episodic cluster headache in 2 randomized sham-controlled trials, so really robust evidence. And here are just 2 case series who have shown that it may also be effective in acetac, which in future is certainly interesting for patients who are unable to tolerate indomethacin. We talked about indomethacin, and if that doesn't work, you either try gabapentin. So you have someone where you think it must be a TAC. It is probably because it's 40-minute attacks, paroxysmal hemicrania. And if then indomethacin doesn't work, then don't let everything let your heart sink. What you do is you try gabapentin, starting with 300 milligrams per day and then tapering up to 1,900 or 2,400 milligrams. And you have very good possibility that you can help these patients. The other possibility would be to describe this one here, and patients can use it themselves. There's a little battery in here, and these patients may have less cluster headache attacks, and it does work in patients where indomethacin worked as well. There are several of these possibilities that you can use. We talked about the pathophysiology, and if you interfere here in the hypothalamus and stop the hypothalamus, then the attacks go away. If you interfere with the occipital gon block here, then a lot of these patients have less attacks. If you interfere here with the ganglion ptericopalatinum, and there is a stimulator used or has been tried and showed in 2 double-blind studies that it does work, then cluster headache goes away. So we can modulate cluster headache on different sides and TACs as well. And we just have to work out in which patients, which kind of stimulation, in combination perhaps with medications, has the biggest opportunity to work. And what I just showed here is the gamma core that would then work as a vagal stimulation. So that would be HOPSA, that would be this here, and you stimulate the vagal nerve on that one side. And here would be the block, here would be stimulation. And I talked about this one, and I talked about this one. So in summary, I'm pretty sure I talked too long already. Cluster headache has some key features: unilateral orbitotemporal pain. It has autonomic symptoms on the same side, and it has a circadian and circadian rhythmicity. The hypothalamus, I hoped I could demonstrate, is a central modulator of that, and it shows next to and this has been like underpinned by neuroimaging, really, but not only neuroimaging, but there are some blunted hormonal rhythms, and they are blunted because the hypothalamus isn't working so well. And don't forget, if we do hypothalamic DBS, we can stop these attacks in 75% of patients. Treatment attacks, oxygen would be in cluster headache would be really efficacious, but not in the other attacks. Triptans are efficacious in cluster headache, not necessarily in the other attacks. If you give triptans, then subcut or intranasal. Verapamil is the medication of choice, and then additive if that is not working alone, to pyrimid or lithium. And if all that fails, probably CGRP antibodies, and there cortisone you can use to bridge. We talked about the gon block, and we didn't talk about this one, but invasive procedures. Intranasal capsaicin, that's just capsaicin like a chili, and if you put that into your nose as a medication. So ask the apothecary to give you capsaicin, 0.01% into the nose on the side of the pain 3 times a day is really painful, but a lot of patients have then less attacks later on. This would be, because it's so painful, like third way medication. This is what first choice medication, what you should try, of course. And if you do all that, then it's rather likely that you can help. And with this, I thank you very much for your attention. And I hope that I talked about what you wanted to hear, and I wish you a nice ongoing Congress. Bye.